access to data, its ability to synthesize knowledge, and the platform of not just the Lancet, but other scientific journals, of which there are hundreds. Given the changing landscape, we have to innovate and we have to come up with new solutions. If we work together in partnership, then we can create that front of knowledge that can hold political leaders accountable to their promises and commitments, and to the lack of them. Thank you very much for your attention, and I look forward to the next couple of days. Thank you.
Thank you so much, Pamela, for your words. Alors, Monsieur le Ministre.
Honorable Minister, we have a surprise for you because this is a launch. When we take a launch, it means that we will unveil something, and this unveiling shall be done with you, with those who will be watching via Zoom. But before that, we would ask you 5 minutes. We have two small messages that have been sent by video, one after another. First of all, the first message is from the representative of GFF. If you are ready, we will listen to this video right away. Thank you.
The launch of the Countdown to 2030 report. This report gives us a clear picture of where we stand in the fight to end preventable deaths of women, children, and adolescents. While progress is happening, the pace is slowing, and in some places it's at a standstill. This is not just a health crisis, it's an economic one. When women and children survive and thrive, entire communities grow stronger, more stable, and more resilient. Every dollar invested in their health and nutrition delivers high returns, unlocking economic growth, employment opportunities that benefit the entire world. And we know this is not just possible, it's also happening. In Tanzania, for example, the Safe for Births bundle of care program led to a 75% reduction in maternal deaths and a 40% drop in newborn deaths. To prioritize, fund, and deliver the most effective interventions for women, children, and adolescents. At the GFF, we remain committed to accelerating progress by aligning financing with country-led plans, scaling what works, and driving smarter investments to make health systems work for women, children, and adolescents. But we can't do this alone. We need to work together, with each of us playing to our particular strengths. The window to meet the 2030 goals is closing, but we still have time if we act boldly and we act now. As the report recommends, it is through coordinated efforts, placing countries at the center, that we will deliver on our commitments to improving women's, children's, and adolescents' lives. Thank you very much, and we look forward to working with all of you.
Good afternoon, everybody. It is my great pleasure to speak at today's launch of the Lancet Countdown to 2030 report tracking reproductive, maternal, newborn, child, and adolescent health and nutrition. This launch comes at a critical time for the global health community. Threats to multilateralism combined with major decreases in international financing for global health are impacting ways of working and the future of health as we know it. This is set against a backdrop of increasing geopolitical tensions and intersections of a complex set of global crises, including conflict, climate change, and economic downturn. These compounding challenges have an impact on our progress towards SDG targets for maternal, newborn, child, and adolescent health. We remain critically off track in achieving these targets, and at current rates, millions of vulnerable lives are at stake. It is, of course, very fitting that you meet today in Africa, where a majority of the global burden of maternal, newborn, child, and adolescent mortality comes from. More than 70% of maternal deaths occur in sub-Saharan Africa. The region also manifests the highest prevalence of child marriage, with 1 in 3 girls marrying before their 18th birthday. The launch today in Senegal is a timely reminder of the leadership of Honorable Mr. Ibrahim Sy, the Minister of Health and Social Action, in advocating for women's, children's, and adolescent health. In parallel, PMNCH has been delighted to spearhead the development of the multi-stakeholder platform in Senegal through the Collaborative Advocacy Action Plan initiative in partnership with Amref Health Senegal. We are reminded that these discussions that we talk of equity, we are not just talking about equal access to care. It means addressing contemporary challenges facing women and girls. This includes countering recent pushbacks on sexual and reproductive health and rights and the emergence of anti-gender, anti-rights movement more generally with put vulnerable lives at further stake. We are talking about ensuring that every woman, child, adolescent, regardless of where they are in the world, has the opportunity to achieve their full potential, free from barriers that hinder their health and well-being. This also means that ensuring integration of care across the whole continuum so that throughout the lifetime women and girls receive the care they need. Addressing these challenges require more than just good practices or programs. It requires partnerships between all stakeholders, including government, civil society, and communities. PMNCH and Countdown to 2030 have enjoyed a rich history together, and I am encouraged to see where a continued collaboration and shared commitment to equity and accountability will make a lasting impact on the progress. Thank you for being part of this vital conversation, and let's continue working together to create a healthier, more equitable future for women, children, and adolescents. I wish you all a wonderful and fruitful event and further discussions. Thank you.
Applaudissements, s'il vous plaît, pour ces messages respectifs de Luc La Violette et Rajad Ramouivi, les deux représentants de GFF et PMNCH. Des applaudissements pour eux, s'il vous plaît. Parfait. Alors, juste avant le panel que nous allons conduire dans quelques instants, c'est le grand moment. Je vais demander à notre belle hôtesse de s'avancer avec le lancement qui sera réceptionné par Monsieur le ministre et Monsieur le directeur Cherbake Faye. Si vous pouvez vous avancer pour ce moment de unveiling du lancement du rapport 2025 sur la SR Mania, s'il vous plaît. La régie en musique.
RMNCH. Music, please. Now,
Merci beaucoup à tous. Merci mes collègues journalistes, les caméras, merci beaucoup à vous. Alors, c'était donc le grand unveiling de la journée. Juste après ça, je pense qu'on va laisser Monsieur le ministre nous dire quelques mots et un peu réagir à tous les commentaires et à tout ce que tout ce qu'il a pu entendre aujourd'hui. Monsieur le ministre, à vous la parole.
Vous m'amenez 2 points. Merci beaucoup. Je pense que le lancement de ce rapport est un très grand moment, surtout pour la communauté scientifique, mais aussi pour les décideurs, mais aussi tous les acteurs qui travaillent dans le domaine de la santé maternelle, néonatale, infantile et des adolescents, et aussi de la nutrition. Et j'ai beaucoup apprécié les discours qui ont été faits par le représentant de la Fondation Gates, mais aussi par le directeur régional du FINEAP. C'est un discours d'autant plus inspirant que ça reflète la réalité. Et moi, cette réalité, je peux vraiment la dire. Il y a cela juste 1 an, je reste toujours, mais momentanément, je suis en suspension d'engagement, enseignant, chercheur à l'université, qui a travaillé sur ces questions-là, et qui pense et qui est convaincu que c'est la science elle seule qui va régler les problèmes auxquels les populations sont confrontées. Maintenant, on arrive souvent à de très beaux résultats scientifiques qui montrent des évidences. Mais la difficulté, c'est la translation. Ça veut dire comment partir de ces évidences scientifiques
Can we start
qui montrent
from
un peu des
evidence-based
tendances, des dynamiques, des évolutions, mais
program
aussi des facteurs
towards factors which may
dynamiques et ces
explain
évolutions.
those trends
Ça veut
and
dire
those
des recherches qui montrent
evolutions? That is to say, results which shows the leverages we can have in order to transform people's life. But the question is, how can I move from science towards action? And I've been working relentlessly so that today we can have incubators, if you may say so, but also experts in charge of using those evidence-based results and transform them into actionable results. That is to say, something we can implement for the society. Recently, I've been in the field. I've been visiting some remote areas in Senegal, Kédougou, Tambacounda. I've been in Kolda, I've been in Sédhiou and Ziguinchor. And one of the questions which transpire is mother and newborn health, adolescent health, and youth health. It shows that this is an extremely important concern, and it explains the fact that it has been given priority in the framework of Senegal Transformation Agenda 2050, which is an element which will contribute to the development of quality human capital and social equity. Later on, I took part to a high-level meeting where we talked about mother, newborn, youth health. And the main advocacy I've heard is that you cannot come and provide some products or medicine while the ecosystem is sick. I'm saying that I came from this field visit. When we talk about reproductive health, when we talk about family planning, when we talk about mother, newborn, and youth health, but it is important if we say that contraceptives are available, when we say that family planning products are available, if we master the whole protocol, if we do not have an ambulance that will take the emergency, if we cannot have ultrasound services, if we can have ANC, if we do not have a framework in order to receive children for quality services, it means that at some point the actions we will implement, we will not have the expected result. It means that it's a whole chain, and we need to invest in the whole chain. Not to say that the product is available while the human being which should have access to this service does not have the necessary tools whereby we can see his condition in order for him to receive the necessary medicine. This is an advocacy I've been saying in Kigali when I say to donors that reproductive health is extremely important. I also said that family planning is important. These are public health requirements. Let's not forget that you cannot implement all those programs without health systems that will take into account the expectations. If we want to tackle all those problems, we need a holistic approach, trying to see how we can globally strengthen the health system and lay emphasis on access to primary health care, because this is one of the drivers of universal health care. And this is one of the pillars whereby we can have a systemic transformation of our health systems. And I do think that this has been properly understood, because generally the budgets we receive would be between family planning, products, training, in capacity building. We say that it is important, but if we today we cannot assess, we cannot have the necessary visits because we do not have the necessary tools, it means that the impact, the main return on investment in terms of family planning policy would have never been successful. And for me, this is very important. This is the reason why today the launch of this publication is important, because it lays emphasis on the elements that I have just described. We have to say it loud. We need science in order to show that we have problems. We need science in order to orient the needs in investment, because science would enable us to develop advocacy documents. And I'm fully convinced that this report, this Countdown Report 2030, is an advocacy document, because today the question is try and go and work with donors while developing bankable projects, and to convince that sometimes and somewhere in Senegal or in another country, some populations and areas that are delayed regarding the various SDGs or issues related to mother, newborn, and youth health care. And this can be done if we can have evidence-based data, and if we have those experts can make the advocacy and convince on the need to invest in order to improve health for mother, newborn by 2030, because we still have a lot to do in order to tackle everything. These are the elements I wanted to share with you regarding what has been said, to show the importance of this report, and hopefully this report shall be used by our researchers, by our scientists, but also stakeholders that are involved in the implementation, but also ourselves in order to highlight our decision-making processes. Thank you very much.
Great many thanks to the Minister of Health and Social Welfare, Dr. C. While the minister is leaving, we're going to support him. My dear colleague of journalists, there will be a press release with the minister as soon as he gets out of the room. I would like the others to remain seated because we will continue our session. We still have the panel and one intervention that was supposed to be done and which has not yet been done. And we're very sorry to Jennifer Harris, who will make his and her intervention in a few minutes.
Forward, Dr. Jennifer, to talk to us about the health system and financing and making it a priority for Lancet and SR-MANIA in a little bit. Just asking for our officials to accompany the minister. Si nos officiels peuvent accompagner le ministre.
Our official can help the minister to leave the room, and the rest will remain here just for a few moments. So let's adjourn. If the official can accompany the minister to leave, and at the same time we will continue our agenda of the day. We are going to conclude with the presentation with Dr. Jennifer, and we will move on to the panel that would close the day. We would like to take a few minutes to the minister and to the officials just before continuing our session. And we thank you all.
Merci beaucoup, Monsieur le ministre.
Thank you very much, Honorable Minister. Thank you for having come. Thank you for your kind words. Thank you for your participation. Thank you very much, Honorable Minister. Now that the minister is leaving and some of our officials, we are going to give an opportunity to Dr. Jennifer Harris Wekejo. If you come forward.
The financing as a priority for SR-MANIA. Thank you so much, and our apologies for earlier. It's a presentation that was supposed to be earlier, but thank you so much. Sous nos applaudissements, bien sûr.
Great. Okay. Well, are they? Okay. Great. Well, it's really a privilege for me to be able to be here with all of you. It's also a hard act to follow. I think all of the speakers that we just heard from, the Minister of Health, already put a lot of the report findings into action for us and explain the implications of our research findings, and so that was really excellent. I also want to thank many of the other people that are here today with us, because this particular chapter, part of the Lancet report, was really a collective effort. So there are a lot of other authors in the room here with us that contributed the analyses to different sections of this report. So a big thanks to them as well. And it's an honor for me to be able to represent everyone. Okay, I don't know how this clicker works. Okay, so I'm just going to go over section 4, which covers health systems and supportive policies. So a little bit of a background. This is just to give you a sense of the framing of how Countdown views the linkages between policies and health systems. So we already heard from Aloisio that a fundamental principle that Countdown takes forward in all of our analyses is this idea that it's a human right to have health, to have universal health coverage. And Countdown also then assumes that this means that norms that have been ratified in international frameworks and treaties around human rights to health should be embedded in the legal frameworks within the country context, and that all of these sort of, at the global level, regional and country level, all of these legislative frameworks and international treaties are really meant to promote accountability. Again, this whole idea that governments and the global community together have a commitment to make sure that all women, children, and adolescents have the right to health and that they receive all of the entitlements that they should. So all of that being said, that also then kind of ties into the framing of this Countdown report around what does that mean when we're thinking about governance. And we've heard already about sort of different power structures. So within the Countdown report, we have an emphasis around the shifting relationship that really what we want to see now is country leadership when it comes to designing their legislative frameworks and the systems that they are developing for their populations, and that it's now time for the international community to better align with country priorities, and that also within that context, within countries, there should be more of an emphasis for devolution to the local level so that health systems and the services that are provided are more designed for the needs on the ground. So all within that, you've heard that since the SDG framework was launched, there has been a lot of revitalization of primary health care, which has these three components of making sure that although there's country leadership, that is including the voices of civil society as health policies and plans are developed, and that when we're thinking about designing a health system, that we keep people at the center. And then also, as we've heard, health isn't just within the health sector. There are a lot of other factors that are underlying determinants of health. So achieving universal health coverage, achieving the mortality gains, the goals that we want to accomplish by 2030 also requires multi-sectoral action. So all that being said, the first part here is, so how well are we doing? Are we reaching our commitments for women, children, and adolescents? So thinking about the policy frameworks, again, the policy framework at a country level needs to cover not just within the health sector, but also social and commercial determinants. So this gets at some of the comments that you've heard before from Tees and from Pam around gender, around other things that really drive access to health and health outcomes. Then also, of course, policy frameworks need to look within the health sector and then also come up with ways for coordination across sectors. So this is just here, there's a lot more data within the report, but just as an illustrative example, we noted in our report that there has been slow progress in countries adopting some key protective policies for women, children, and adolescents. So here are just a couple examples of policies that have been around for a really long time, and we still see that about 83% of low and middle income countries have not yet adopted basic maternity protection convention, and we're still not making very good progress on the International Code of Marketing of Breast Milk Substitutes. So that's just the first step, is having the policy in place, but we all know that that's not going to result in the changes we need to see. Those have to be followed by really good implementation of those policies on the ground. So in this case, just as an example, we know many of the countries, most countries have laws against child marriage, yet we're not seeing as much progress in as far as implementation is concerned. So moving now into the health system part of the report, we know that we need to be investing in our health systems so that they are responsive and and resilient to the health needs of the population. So although every health system is very unique to the country context, there are certain elements that are fundamental to health systems in all of the countries that we examined in the report. One of the main findings that we were describing in the report is, and you saw this already with Aloisio's and Agbesi's presentation, looking at trends over time. So we have made notable progress in reductions in maternal and child mortality. What does that mean then in terms of what countries need to do to respond to those changes in the epidemiological and demographic shifts, to develop programs and policies that will address the emerging, where the concentration of mortality is occurring? So for example, as countries start to do well with scaling up things like their immunization programs, and things addressing leading infectious killers of children, they may end up having more of a concentration of maternal and newborn mortality in the intrapartum period. So in that kind of a context, then countries need to respond by scaling up emergency obstetric and neonatal care, and then also care for small and sick newborns. And with that, then they can make more progress towards their national and global goals. The other issue, of course, is we've heard that there are a lot of shocks that are happening, climate change, the finance disruptions, and so another really imperative message in the report is that we need to be thinking about developing health systems that are resistant and resilient to these kinds of shocks, and that will require investments in each one of these components of the health system that you see in that figure there. So on that, I'm just going to go over a few of those different building blocks just to give you a sense of some of the data that's in the report. The first here is that in order for us to have strong, resilient health systems, we really need to address the huge shortages of human resources. Human resources are really the backbone of the health system, and what we're seeing here is that there has been little improvement in health workforce density across most of the regions that we analyzed and across country income groups. You can see that there's a huge difference between the upper middle income country, which are the highest bars, and then what we're seeing in terms of density in low and middle income countries. Also, in terms of a regional distribution, South Asia, Eastern and Southern Africa, and West and Central Africa are lagging the farthest behind. What are some of the underlying factors that are impeding progress with increasing human resource density? Some of these are really large transnational problems, such as the brain drain, a lot of health workers leaving countries and going other places where they may have more opportunity, and then also just issues with attrition if they're working in environments that are not enabling, that may result in a lot of attrition of health workforce. So this is then kind of thinking through, there are lots of different opportunities for countries to think about strengthening their health systems. How can they tap into the private sector to increase the availability and accessibility of services? So to explore this, we did a little bit of an examination of some of the proportion of services that are provided in the public versus the private sector for some key maternal, newborn, and child health interventions. So what you're seeing on this slide is that although there's variation at a country level, looking across the countries that we examined, all low and middle income countries, you can see that for most of the RMNCAH services, they're still most of them are being provided in the public sector. The exception is cesarean section, which we heard about earlier today. So just take away from this is that there is a lot more opportunity for countries to think about stronger engagement with the private sector, provided that they're able to maintain strong oversight on the quality of the care that's being provided in the private sector and other issues. So moving along, we've been talking a lot about evidence-based interventions and trying to ensure that as countries develop their plans, their health strategies for women, children, and adolescents, that it's evidence-driven. But this is really impeded if their health information systems are weak. And so what we found in the report is that there's still a lot more work and investment that's needed to improve the health information systems across low and middle income countries. And most low and middle income countries still have weak civil and registration and vital statistics systems, which means all of that data that you were seeing before around mortality trends is hard for countries to have a real clear sense of what's happening in terms of births and deaths and how many services they need to be planning for. Also, just one other point to note here is that we see that information systems are also impacted by shocks. So in 2020, when we had the COVID pandemic, that really did impact data collection efforts, including the census as well as surveys. So it's also just, again, what does that mean in terms of building health systems that are resilient to any future shocks, including the fact that now the DHS program has been discontinued. The emphasis and the message from the report is that we do need to be investing more in countries' routine information systems, as well as coming up with innovations around rapid and affordable data collection approaches. Moving into the health financing, the basic emphasis here is for you to see across the board for these 4 different graphs that there's a big change between the MDG period and the SDG period. A lot of other speakers before me have noted that the pace of increase in terms of current health expenditure, or the pace of increase in most positive things, was faster in the MDG period. What we're seeing in the SDG period is a slowdown in the increase in the current health expenditure, and no increases at all in sub-Saharan Africa and low-income countries. Similarly, in low and middle-income countries, there weren't any increases in government health spending as a proportion of current health expenditure, which is something that we would want to address, especially in the current environment where there's less and less international assistance. And then also the other alarming point is that out-of-pocket expenditures still remain a very high proportion of financing, including in upper middle-income countries. Again, now just looking at the external financing for RMNCH, we see the similar kind of issue of a slow pace of increase after 2015. And then this is just across all regions and income groups. This also occurred, just noting again that the report was trying to have some specific focus on the implications of the COVID pandemic. And we do see that there was a potential displacement of funding for RMNCH around the time period of 2020 because of the COVID response. This is also the other point on this is just to note that the aid flows vary across the continuum of care. Child health received the most funding, and then we had the least funding for maternal and newborn health. The other point to be made here, and it's already been stressed, is that the analysis, the historical trends pointed out that USAID was the largest donor from 2010 to 2021, and that is now jeopardized. So just the last couple slides here is that we also did some qualitative research asking experts what they thought. Why is there this stagnation in global priority for women, children, adolescent health? And the outcomes of this qualitative analysis were twofold. So we've grouped them into external reasons and internal reasons. In terms of some of the main findings that came out of that research for external reasons is some of the issues that we've already heard about today is the competing priorities in health, conflict, climate change, pandemic preparedness, and then also that RMNCAH has been sort of it's been included as part of UHC, but maybe overshadowed by the Universal Health Coverage Agenda. The other is some waning support for multilateralism and also sort of an erosion in agreement in international human rights framework, which is really concerning given that all of public health is premised on the idea of human rights for health. And then also we've noted that there are some shifts towards authoritarian governments, which also undermine some of the principles we mentioned earlier around devolution and decentralization so that there's greater autonomy at the local level. And then also repeating the point about abrupt changes in the international financing landscape as a threat for RMNCAH moving forward. And then lastly, the other issue that was explored were some of the internal reasons for stagnation in global priority for women, children, and adolescent health. One of the key issues is underfunded coordination mechanisms at the global and regional level. And then also, there was in the MDG era, the UN Secretary General had the Every Woman, Every Child initiative, which has been dismantled, so there's been less visibility on the global space for women, children, and adolescent health. Internally across the RMNCAH continuum, although there is acknowledgement and support for the continuum of care, there has been a lot of fragmentation in terms of a focus of different groups focusing on specific interventions or specific population groups that sometimes has detracted from full support of the continuum of care. And then that just ties into this issue of us needing to come together as a community to develop a more compelling framing so that we're more unified and coordinated as we move forward, especially given the tight timelines now for the SDGs. And that is all. And now I'm going to hand to Thies and Sheikh.
Thank you so much, Dr. Jennifer. Thank you very much. We are at the conclusion of this part. I think that maybe Professor Thies would like to conclude. In the meanwhile, we're waiting for the panel. Il y aura donc un panel dans quelques minutes, juste après la conclusion de Professeur Thies. Je demande à nos panélistes de se préparer, juste le temps d'une pause de 5 minutes après la conclusion de Professeur Thies. Okay, go ahead.
So I was only the backup to Sheikh, but he's still seeing the minister out. So I'll see what I can do. So on the progress assessment, I think our conclusion is quite clear. Mortality continued to decline in almost all age groups in all regions. Stunting in children under 5 also continued to decline. Coverage of interventions improved, most prominently in the lagging region of West and Central Africa, and most among the poorest households. And these positive developments may have benefited from some modest country health systems strengthening. However, the rate of improvement was really slowing down, and I had actually some slides. I don't know if... Okay. Oh, you were trying to get my attention. Okay. Well, because I don't think you want to be looking at me all the time. Right. And so progress is falling well short of the pace that's needed to get to the SDG targets. So what were the main contributors? As we heard, there were really the positive trends that we saw in socioeconomic indicators and political determinants of women, children, adolescents' health are facing stronger headwinds, greater obstacles, and things are slowing down. And because mortality is declining everywhere, there's an increasing need for more advanced and high-quality services for all women, children, and adolescents that require strong health systems. So the progressive concentration of child mortality in the perinatal period, for example, requires universal access to more complex services, such as intensive care units for small and sick newborns. And we have Joy here, who is the world champion on this issue, and I'm sure you're going to say something about that. And then last, as we heard from Jennifer, priority for RMNCH has waned and led to some changes that were not favorable for this topic. So we identified 5 priorities for action. Number 1, explicit focus on sub-Saharan Africa. Economic challenges, armed conflict, food insecurity are disproportionately concentrated in sub-Saharan Africa, a region already burdened by weaker health systems and higher levels of poverty. And particularly West and Central Africa lags in nearly all health indicators. So increased prioritization is really essential, and as you remember, more than half of the population is under 20. The Countdown and the Lancet are already making one little step in this direction, so during the next 2 days, 30 experts, many of those who are in the room, will brainstorm about the contents and the best and most useful way to synthesize all the information that's out there and look for a way forward. Second priority for action, strengthening health systems for women, children, and adolescents' health and nutrition. So priority strategies should focus on health workforce strengthening, distribution in the country, and of course, much greater numbers, including also approaches to address the brain drain, the emigration and attrition of health workers, but also protecting health budgets from fiscal constraints, innovations in commodities and service delivery strategies, and quality of care improvements. Implementation of these strategies will require increases in financing, especially greater domestic financing for women, children, and adolescents' health, as well as continued commitment from external donors, who seem to be fewer and fewer, but to support the countries in greatest need. Third priority for action, safeguarding progress against crisis. The most pressing need for action is action that safeguards health, education, and social protection services for women, children, and adolescents in countries that are affected by economic downturns, debt servicing payments, disasters that are related to conflict, environmental change, and epidemics. So our report was, of course, completed before the major external aid cuts, the freeze, but it seemed, I don't know, freeze was, we used the word freeze, but it seems like more permanent, by the Trump government in the United States, and also later announcement, much more quietly, of the UK about a 40% reduction in their development assistance budget. So the Lancet actually invited us to add a comment to our report as a postscript, and in which we express, beefed up by some of the calculations that were done about how much actually this contribution was and is going to disappear in some countries. So that we're deeply concerned about these abrupt declines in funding for health and call for protection of programs in women, children, adolescents' health. I also think the comment by the minister in the Lancet is very good, because he actually gives some really practical ways in which he thinks about how to respond to these big changes. Priority number 4. Yeah, that's our bread and butter. We have to keep ourselves in a job, although that's getting harder and harder. Data and accountability. So the analysis in this report expose major data gaps, including for maternal mortality, causes of death, morbidity, quality of care, and health system and policy indicators. Much information comes from the Demographic and Health Survey, the DHS, which has ceased to exist. That also requires some real thinking, including for us and our friends from Pelotas who make a living out of the DHS analysis. Much information, so countries will have to make new investments to be able to monitor progress and make efficient data-driven decisions. So overcoming these gaps requires a sustained global and country investments in health information systems, as well as methodological innovations, such as remote data collection approaches. To guide policymaking, country data should pay ample attention to equity by district, by region, socioeconomic position, and other relevant dimensions. And then data-driven accountability for all stakeholders, which was an imperfect but seminal pillar in the MDG era, must be reinvigorated. Priority action 5, last one, revitalizing reproductive, maternal, newborn, and child and adolescent health and nutrition. Enhance global coordination and compelling ideas on why women, children, and adolescents should remain at the core of a health and development agenda are needed to drive collective action and sustain progress. These efforts should include building a narrative around emerging global priorities, such as universal health coverage, or the emerging, it's not emerging anymore, the non-communicable disease agenda, showing that reaching women, children, and adolescents with high quality services is central to everything. And similarly imperative are arguments about RMNCH, or women, children, adolescents, health and nutrition, should be at the center of dialogues on other priorities, such as climate change, given that women, children, and adolescents are highly impacted and there are potentially intergenerational effects. So looking forward to, if we still have time, any further deliberations in the panel, and thank you for your attention.
Thank you so much for this brilliant conclusion. Yeah, we can give him another round of applause. Thank you so much. Alors, on va enchaîner avec la dernière partie de l'agenda dans quelques minutes. On va prendre peut-être 5 minutes pour souffler. Ensuite, on enchaînera avec le panel. Je vais demander par contre aux participants au panel de déjà se préparer et peut-être de s'installer. Je vous donne le titre et le thème du panel dès à présent. Nous allons parler de preuve à l'action. Que signifient les résultats du rapport 2025 pour l'Afrique subsaharienne et le monde? Un panel qui va être modéré par Dr Cheikh Mbake Faye, que vous avez entendu, le directeur de APHR West and Central Africa et directeur de l'initiative Countdown. Il partagera ce panel avec Madame Awa J. Dian, Regional Manager de AMREF West Africa Hub et représentante de la société civile de AMREF et de PMNCH. Professor Joy Lawn, London School of Hygiene, Tropical Medicine Academic Expert. Dr Samba Korsar, s'il est toujours là, du cabinet du ministre de la Santé du Sénégal. Et Dr Senen Hunton, qu'on a eu le plaisir d'entendre tout à l'heure, qui partagera aussi ce panel, qui est donc le directeur régional pour l'Afrique de l'Ouest et l'Afrique centrale de UNFPA. Alors, toutes ces personnes que je viens de citer, si vous voulez bien vous préparer pour ce panel qui va commencer d'ici 5 minutes, le temps d'observer une toute petite pause. Merci bien. Panel. Nous avons pris un peu de retard, donc ce sera important qu'on enchaîne dès maintenant. Si la régie peut activer les micros. Alors, je vais demander à chacun d'allumer les micros pour tester.
Testing, testing.
This one works.
Should be okay, right?
This one works as
All right.
well.
And this one?
It does. It's working? Ok, parfait. Alors, le temps que chacun retrouve sa place tranquillement, nous allons introduire le panel. C'est la dernière étape de notre agenda du jour. Comme je le dis, nous avons pris un peu de retard, donc on va y aller dès maintenant. Je vous le disais tantôt, un panel sous le thème des preuves à l'action. Que signifient les résultats du rapport 2025 pour l'Afrique subsaharienne et le monde? C'est le titre du panel, le thème. Un panel qui sera modéré par Dr Cheikh Mbacké Faye. Nous vous l'avons présenté plusieurs fois aujourd'hui. Il s'agit du directeur régional pour l'Afrique de l'Ouest et l'Afrique centrale de APH+RC et le directeur de l'initiative Countdown. Nous avons Madame Awadji-Dieng, qui est manager régional de AMREF pour l'Afrique de l'Ouest et représentante de la société civile pour AMREF et RMNCAH+N. We also have Professor Joy Lawn from London School of Hygiene, tropical medicine academic expert in RMNCAH+. On a le docteur Samba Korsar du cabinet du directeur de cabinet du ministre de la Santé et de l'Action sociale du Sénégal. Et nous avons Dr Senen Hunton, que vous avez entendu tout à l'heure, qui est directeur régional pour l'Afrique de l'Ouest et l'Afrique centrale de UNFPA. Voilà les membres de notre panel. Je vais donner la parole tout de suite au modérateur pour qu'il introduise. Bon panel à tous.
Merci bien. Merci Madame la modératrice. Je pense que c'est un moment très crucial de cette assemblée où vraiment nous allons maintenant aller au fond, parce que c'est bien de présenter un rapport, mais c'est bien également de l'expliquer et de pouvoir voir un peu ce que ça veut dire par rapport aux actions, par rapport également à l'implication programmatique.
Programmatic implications. And today we are honored to have a high level of science here. We have an expert with the civil society, Mrs. Awadji. She's an eminent expert in this level. She's working with AMREF for some time now. And also we have, at the level of academias, we have Professor Joyland. She will also talk about the specific issues, and he's director of UNFPA. In fact, he is our guest. We are happy to have him with us. And the permanent secretary of the Ministry of Health, Dr. Samba Korsar, is wearing his former hat. He's not the permanent secretary of the Ministry of Health here, but he's an eminent researcher. He spent his whole life working on issues of health in Senegal. As well, he's been able to manage some programs in Senegal. Samba Korsar was at the heart of ethics in research in Senegal. We are very happy to have him with us today. To start with, I would like to talk to Mrs. Awadji. Mrs. Awadji, she's the manager of AMREF. This countdown report, which we are sharing with you today, highlights the importance of civil society voices in order to contribute and orient political and programmatic priorities. But at the same time, we highlight the issue of civil society space. But here we have to look at the first question, how civil society organizations can better work in terms of intervention based on evidence in terms of RMNCH in a limited resource context. In my second question is, according to your experience, what are the concrete measures which can be taken in order to fill the gap between the community-based interventions and national political frameworks? Thank you very much, Sheikh. Thank you for inviting me. Thank you for having me during this panel. I will speak French. I did prepare myself in English. If you need your headsets, kindly take them.
Has demonstrated a strong commitment to PMNCH, particularly through its leadership in Malawi's Collaborative Advocacy Action Plan initiative. And this initiative aims to enhance accountability and accelerate progress in women's, children's, and adolescents' health. It's working also on the same for Senegal, where we just completed or conducted a mapping of Senegal's RMNCAH commitments, which will also lead to a collaborative advocacy action plan involving partners with their various contributions. So to answer your first question, as CSOs, we play a key role in helping countries achieve their health targets. However, there's a lot that needs to be done in making sure that our interventions are actually solving the right problems. So the first point that I would like to make is to create, on advocacy, to create a strong network for RMNCAH advocacy. We have a tendency of working in silos, and this is not deliberate. This is just how the system is. We tend to work in silos, and we tend to not work together in defining priorities or where we need to focus our interventions. And I think this is very important for us to be able to come together on a table and decide on how we want to tackle certain issues like advocacy and see how we can synergize to make our efforts count more for different interventions. A second point would be to conduct a mapping of regional needs and priorities. Against the fact that we work in silos and the fact that we don't collaborate sometimes leaves some gaps in the support that we provide to countries. And conducting this mapping of the regional needs and priorities would help us know where the needs are exactly and what we need to do to address those needs, and also where we need to focus our funding and our efforts. I think the Ministry of Health should be the entity that orchestrates this, because without the Ministry of Health, anything that we do will not really account to anything. So the Ministry of Health should be the organizing body for us, civil society, to be able to assist and to support it in achieving its targets. The third point would be research. We've heard many times since we started this workshop about research and data. Research is evidence. We cannot implement evidence-based without having research. So we all need to invest more and also find ways to fund research. Because as CSOs, we rely on donors to fund the activities that we implement. And a lot of the time, that funding doesn't come with a requirement to do research. And so if that's built into programs from the beginning, we know that we need to do that, and the ministry can also expect results from the contributions that we make. So I think it's something that I can't put it on one actor. It's not on the CSOs, it's not just on donors, it's not just on the ministry. It's a collective effort that needs to be made for us to get to the point where we get that evidence that we need to be able to implement. And then the fourth point that I would like to make, it's in terms of resource mobilization. I think we need to be more creative on resource mobilization. I don't mean to be beating a dead horse by talking about funding cuts and everything. We all know what's happening right now. And it's not just the US government. It's, it's the UK, it's the EU. They are all reducing funding. This is not necessarily a bad thing for us who are on the receiving end. I think that it's a wake-up call that we need to revise, that we need to rethink the way we fund our activities, the way we fund our interventions. And this is something that also we can work collaboratively in coming up with opportunities to do that. Yeah, so I think those were the 4 points that I wanted to make on the first question. Maybe if I can go just quickly on the second question in terms of the steps that we need to take to bridge the gap between community level interventions and policy framework. One example is inclusive policy making. I think we have a great example. Dr. Doucouré is here. AMREF supported the national strategic planning for the Directorate of Maternal and Child Health, and it was an inclusive process where it was the first time that the Federation of Differently Abled People National Association took part in this process, and their needs and inputs were taken into account. And I think this is a very important thing to do because it ensures ownership of national policy, of national plans, where even at the operational level, people know that they are contributing to a larger goal. Codification of interventions within the national policy. I think this is important in capitalization, which is also another point that I wanted to raise. If all the interventions that we make at every different level are codified, it allows us to be able to capitalize and also to track progress on the different interventions that we are all trying to make. Just maybe one more, priorities definition for each geographical region. I've mentioned that earlier. That's very important for us to be able to know where we need to focus our efforts. I'm going to leave it at that.
That's
Thank
wonderful.
you.
I think, I'm not sure where this is this working? Est-ce que ça marche, ce micro-là? Is this mic okay? Is this okay now? Okay. Yeah, thank you so much. No, I mean, I was just going to commend you for this important point that you've mentioned. I think one of them is replacing a little bit of research, and I think that's what we do here. But it's so important to see what are the perspectives, what are the thinking of some of us here. So this speaks to Professor Joy Lan, who from London School. And Joy, we know you've been working over the years on small and newborn and sick kid and all of that. But you see the report highlight that driving maternal and newborn mortality to achieve SDGs will require increased access to emergency obstetric care and small and sick newborn care, which is not the case probably. But it also emphasized the gap in quality of care and in data needed to monitor service quality, specifically for that group. My question are, what are the most critical evidence gaps that need to be addressed to accelerate RMNCAH progress, specifically in sub-Saharan Africa when you look at that age group? The second one, how can academic institutions like London School collaborate more effectively with policymakers to ensure evidence translation into accountable strategies for improving health of women, children, and adolescents?
Merci, Sheikh. Bonsoir tout le monde. I'm afraid I will now move to English, but I want to start by congratulating you all for being here and congratulating everybody for the delivery of this really beautiful report, Born Today. I think I'm being asked because apart from Tis, maybe I'm the only person who was in the room for the first Countdown report 20 years ago, right?
And Senator too.
Yeah, so I'm an old academic, but actually in those days I was in the civil society, so I have moved chairs. And then I want to thank Sheikh for this impossible question. What are the research priorities for all of Africa, for all of RMNCAH? So you'll be glad to know I'm not going to try to answer that question. But I want to think about this moment we are in now. So it's a scary moment, right? If you look at the funding, if you look at DHS going, if you look at the weakening multilateral system, and because I'm now an old person, I can look back to how it was 20 years ago. So 20 years ago, the reason that Countdown was born was entirely because of a similar problem. We had 10 years to go. There was at that time, there was none of the vertical funding, like Gavi and Global Fund didn't exist. There was almost no funding for RMNCAH. There was really slow progress. We had few surveys and very weak data. So if we look back to that time, what has worked to bring a change? So actually, it's amazing that we have the data that is being presented here. It is amazing that in that time period, we've had a 40% reduction in maternal deaths, around a halving in child deaths, and neonatal deaths have been reduced by a third. That's amazing. It's not enough, but what did we do? And I think we need to go back to what we did then to say, what do we do now? So what did we do then? We did exactly what we have here. We looked at the data, not just saying everything is bad and everything is the same. Across Africa, we have so many different countries, and it's different. It's not the same. People who just say this in Africa are not understanding that there are many different countries, and differences even between North and South Nigeria are hugely different. So we looked at the data. We brought an alliance of people together. Yes, academics. Yes, the UN. And yes, non-governmental organizations. But that's not enough, because if you leave academics on their own, what do? They love to admire the problem. They will describe the problem, they will describe it again, they will describe it in more detail. But describing a problem doesn't solve the problem. Yes, it might make it a little bit more visible, but it doesn't solve the problem. So if we're going to solve the problem now, yes, we need to describe the problem. We need to describe it so politicians get it, not just so academics get it. But we need to come with some solutions. So I want to give you 3 solutions instead of 100 research priorities. My
Very
apologies, Sheikh.
Thank you.
So we absolutely must go faster, not slower, despite this situation. So here, many of you are coming from Senegal, but also from across Africa. And African governments want to meet SDGs, right? They want to. So what can we do to help people go faster together? So first of all, I think it was said just now by my colleague, but also said very clearly by Jennifer earlier, is we mustn't compete with each other. So if it's reproductive, maternal, newborn, child health, nutrition, it's already half the alphabet, right? But we need to not compete between ourselves. If we want to make the case to go faster for maternal health, remember that for every 1 maternal death, there are maybe 10 stillbirths and neonatal deaths. So also count them, because it'll make it more cost effective for putting input in. So we need to speak together. We need to look together at the continuum of care packages that we need, and the bundles and the interventions. Let's not just shout for one thing.
Absolutely.
You know, for a lot of West Africa, the single most cost-effective thing is probably going to be unmet need for family planning. Absolutely critical. let's not forget to shout for that as well as shouting for obstetric care and for neonatal care, which we need to go faster as mortality comes down. So we need to shout together. We need to shout together for the continuum of care. And then, very importantly, we need to think about how we can learn together. So across this room and across Africa, there are successes. Even in the UN report for neonatal and child mortality, Senegal was lifted a whole page of really amazing, thoughtful systems change led by the government of Senegal. I've just been part of working with the government of Malawi, looking at their progress for neonatal mortality rates. Malawi is probably the only country on mainland Africa that is likely to meet the neonatal target. What are they doing? We can't tell you everything now, but there's a webinar that was done last week. There are ways to learn. So let us learn from each other so we go faster together. Let's not reinvent the wheel. If one country has a successful education thing for obstetric care or for newborns, let's share it. I would encourage you to join. For example, if you're looking for newborn care tools, we have a toolkit that has 55,000 users per year, 1,000 tools in 15 languages. Don't just invent a new tool. Go and see what's there and adapt it. So that's what we can do to go faster together, those three things. I think the really fundamental extra challenge we have is the data. So if we are talking about a mortality transition, where you start with very high mortality and most births are at home, you can only do primary health care. Then as you move into facilities, you have an essential need to improve your systems, whether that's for obstetric care, for neonatal care, or for child health care. And in most countries across Africa where we're doing that, we're using DHIS2 indicator aggregate data. But as we go forward, that's not good enough. You have to have individual level data or you can't measure quality of care. So it's now an urgent call to all of us as practitioners and as researchers. If we don't have surveys, how can we change our routine data faster to be fit for purpose? So this is a really critical way forward. So for academics, if there are things that we can help with, I think to help that data transition, not be like a project, but be a government direction of travel. And then for making the economic case for investment. We can no longer easily make the moral case for investment. We have to make it based on a return on investment. And to do that, we need more economists in Africa. So I want to ask, how many economists are there in the room? Thank you very much, Melissa. It's not enough. So for the next Countdown meeting, we need a really key focus. If we're going to make the case for the money, we also need to have more economists across Africa. So I will stop there. I think going faster together is critical, and I'm looking forward to the next few days, and I think especially on the data and making the case for the money.
Thank you so much, Professor Joy. I think you made a very you make a very strong point about investment, because that's the point. Because I think this is very timely now, and we know all the issues that we are facing. It looks like global funding is going to, I don't want to say stagnate, but may even be drastically reduced. So, and that speaks to how now countries are going to adapt their strategies. And I think I hear you that this is the right moment maybe for countries to leverage on it and make sure that, they tap into their own resources. They interrogate their strategies. I think that's also a very good point. So thank you for that. But if you look at this global level perspective, Dr. Senen, I think the UN agencies, there are a lot of expectation from the UN agencies. We all say the UN are the door to go. So the report actually highlights that UN agencies remain key partners in supporting countries in the effort to improve women, children's, and adolescent health, and helping to align partners around country priorities and a unified framework for RMNCAH. That's what the report says. But how can UN agencies support countries in scaling up evidence-based intervention while ensuring contextual relevance? That's the first one. And the last one is, what lessons have been learned from the recent UN initiatives that could be applied to accelerate RMNCAH progress in sub-Saharan Africa specifically, which is a region that Countdown has identified as a region where attention and focus is much needed.
So you see, like Professor Joy said, the question from Mr. Fai is, the questions are really, really long, but I will try. The first part, I think I will speak to 3 points. Partnership, very important, because when we're talking about sharing evidence, who are we sharing the evidence with? And I think the UN funds and programs that can help, of course, generating the evidence like we are doing, but sharing them with different stakeholders. Making them, like Professor Joy was saying, accessible for different stakeholders to understand. We have opportunities most of the time to discuss with different sectors. If I take just for my agency, we discuss with Ministry of Planning and Economy for the program. Then we have sectoral program with Ministry of Youth, Ministry of Gender, Health, of course. And we need to make sure that this type of evidence is going to these different sectors. So partnership across sectors in sharing the evidence is key. The second thing that I will say is alluding also to what you say. You know, when you speak after Professor Joy, you don't have a lot to say. What I have here is, I said, knowledge sharing and exchange of good practices. You were mentioning about Malawi. But think about that. I just came from Uganda on African review of the Sustainable Development Goals. And they asked me to lead a meeting like this on community health. And I remember 10 years ago, we organized something specifically on the Ethiopia health extension workers. And we haven't made progress in sharing those experiences really in terms of implementation. Just in this region, think about it if you look at this report. We have countries like Burkina Faso and Mali in the Central Sahel going through crisis for the last 10 years, and yet they have better MMR, look, Professor, than here in Senegal, than Benin, my country, than Cote d'Ivoire, which are countries with better GDP and more stable. But there is something going on in these countries that we all need to learn from. And I think we can, as UN agencies fund the program, organize those platforms so that countries can talk to each other and learn from us. And the third thing that is coming to my mind is using the mechanisms that we have as UN. I mean, Jennifer mentioned, for example, some of the convention. We have the Commission on Status of Women on CDP. We also have the voluntary national reviews. So, because accountability, we need to hold the government accountable. And so we can use those processes to bring the finding from this type of report and say, look, this has been, you have signed up to this first. These are very well established reproducible evidence, and this is what the trend is looking like, and you can then take lesson from that. The last thing on that is, for example, I mentioned I'm from Benin, so my government, they just look at the latest report on MMR, and they were quite unhappy. And they say, you are from this country, you know how much investment we are doing, and yet the MMR is what it is. And so this is something that we are trying to tell them that they need to learn from others. The last point, I asked my colleague to share one flyer with you, and it is very easy. It has a QR code. And that's, to answer your question, I would like to share that experience that we had. And like Professor Joy mentioned, we came at a point after 30 years investment in this area just to say, what is it that we are missing? And so, yes, we have academia, civil society, the usual suspect. But this time we said, no. Let's bring those who have managed at the government level this area, minister or former minister or professor of economics, you name it, traditional leaders. So we brought all these people. Agbesi was supposed to come, but he intervened from John Hopkins. And we ask ourselves, what is it that we are missing? We have the data, we have everything. And that's that flyer that I mentioned to you. And so, one thing just to illustrate, something I have never heard before, and it didn't come to my mind. And maybe Ms. Pamela, who have been working on the 21st Century Lancet Commission, you will recall Professor Nicolas Meda, he's in that commission, and you are he came up to us and said, we all in this field, we don't first talk about the other determinant, but it requires political will and commitment as the number one. It's not that we don't mention it, but he told us how they were able to leverage presidential election to put in the manifesto of the candidate, both opposition and whoever will win, so that at that level, they were able already to put in whatever is the big three, the B5 that they claim, the importance of saving mothers and children. Because then when it happens, when we have Senegal and we hear it from the minister, Vision 2050, it is already there. And it's no longer a discussion at the cabinet level whether or not you will invest in that, because that's the president's priority.
Yes.
I never thought about it. We sit in academia and the UN. So that's one. The second thing, we were looking at the data in this region. I think Jennifer mentioned that we have child marriage. Child marriage, the 9 of the 10 highest rates in the world are in this region.
Exactly.
Right? So really, if you look at the data, something we did not present, but it is in the report, who are the ones dying most? It's the adolescent, when you look at it, in this region. Because they are married off, they get pregnant very early, they don't have the choice, the risk is high, and we have many dying. So we said, we can continue to do what we are doing. We need to shield the adolescent girl, the girl child. So it's not health, right? But it's an important determinant. The other thing that we learn from that is that when government are deciding where to put their investment, because there were some IFI's director of World Bank, they told us, it's good, you guys, you seem to be talking to each other, but you need to change strategy. If a government is saying, infrastructure is the one I want to do, how do you hook maternal, newborn, child health to infrastructure?
Exactly.
If they say, let's think about it, they say, okay, for me it's industrialization. For example, in Central Sahel as we speak, they told us all UN partners they wanted 4 things. Come together and support us on food system and agriculture, on transforming education, on making sure that you work on digitalization, and work on industrialization. That's not my field. But they are telling me that that's where you need to make sure that your stillbirth and my maternal mortality, we make sure that we hook to that. So that's how we came up with the imperative for us to think societal, what you call holistic, and multi-sectoral. So that's where I will end. And I thank you very much for this opportunity, for sharing that with you. Thank you.
Wonderful, wonderful. I think you made a very strong point about this complementarity, actually, because what you're trying to tell us is that whether you look at, you cannot look at maternal mortality aside without looking at sick and newborn and other determinants. And they all speak together, and they should be looked at holistically and come up with the real solution. But that solution is not very easy, because government always tell you that they have a lot of priorities, they have a lot of issues, challenges. And one of them, actually, if I speak to
Dr Sambakor Sarr. Dr Sambakor, je pense que, après vous avoir remercié vraiment d'avoir assisté à cette réunion, je rappelle que Dr Sambakor a fait un commentaire qui accompagne ce rapport. Et dans ce commentaire, il essaie de nous dire quelle est la voie que le Sénégal est en train de prendre pour adresser, pour réduire les inégalités, mais également pour aller vers l'atteinte des étés. Je pense qu'il va y revenir. Mais en disant ça également, nous rapporte, nous dit que ici, on a une analyse vraiment approfondie des progrès réalisés en matière de santé. Il souligne également les obstacles liés à l'utilisation des données. Donc, autant on génère des données, mais autant on ne les utilise pas, ou bien on les laisse là-bas, on les laisse dans le tiroir. Et donc, si on doit définir les politiques et les programmes, si on doit aller vers la vision 2050, n'est-ce pas, de son Excellence, Monsieur le Président de la République, Bassirou Diomaye Diakhar Faye, donc, qu'est-ce qu'on doit faire? Et l'une des questions, c'est quels sont les principaux défis? Pourquoi les gouvernements sont confrontés à un problème pour traduire les données en politique et en pratique ou bien en programme réel de SRMNCAH? Comment peut-on les aider à surmonter ces problèmes-là? Ça, c'est le. Et l'autre chose, c'est que comment les gouvernements peuvent-ils renforcer la collaboration intersectorielle pour s'attaquer aux déterminants de la santé qui influencent les résultats? Et l'un de ces déterminants-là, il l'a bien dit, la question des mariages des enfants. Parce qu'on a vu que donc, ce sont des adolescents, comme il a dit. Et ça, ce n'est pas une question de santé seulement. Il y a d'autres personnes qui doivent être interpellées. Quelles sont les stratégies? Qu'est-ce que vous pensez faire pour faire en sorte que ces personnes-là soient également dans la vague? Merci.
Merci beaucoup. Je pense que ce que vous venez de dire nous renvoie à des problématiques qui sont régulièrement évoquées par les chercheurs. C'est-à-dire, nous produisons énormément de connaissances.
Of knowledge, a lot of knowledge, but these are knowledge that are used just for publication. So the decision makers are looking ways to solve their problems with the means that are available, and the researchers are also on their side developing collaborations, and they produce knowledge and they make publications. People are asking questions. We have excellent researchers in Africa who are developing very productive collaborations with their colleagues from the other continents, but we do not feel the impact. And this is what brings the politicians or the policymakers not to be ready to put money in research, because they see the research just like an expenditure. They don't see research as an investment that can transform the daily lives of their populations. But this means that we will have, at the level of the researchers, we have to revisit their approach or their conception. The hermetic language which is used by the researchers makes that the decision maker does not look at their document. We really have skills or competency that should exist, that should among the researchers to enable them to better make the result of their research be used. Unfortunately, their skills are very low in that regard. They only have competence in how to communicate and how to convince the decision makers to base on the data that are generated. They have very little knowledge in that. In other words, the researchers sometimes cannot communicate with the decision makers. So that's a problem. When you send Sheikh Mbake to the Minister of Health, make him convince the minister to invest more resources on health of the child and the mother. Shambake would say that we'll go visit data to say Jurbel, Tuba, and so on. These areas are like this and like that. We have a lot of death, and the framework is not very good, and research has shown this and that, etc. So you see. So the Minister of Health, Dr. Si, will say, yes, okay, you are right. This is an observation that we also know about. But after, and then, and what? So what? So what can I really do as a minister? Because I don't have money, as you see. I don't have money. And the position that I am occupying now and the level of decision that I have is very, very limited in relation to what may bring the government to guide or to orientate other resources, to allocate other resources to this sector. So, honorable researcher, you are very kind, but you don't bring me much in relation to what I am looking for and what I want to do in relation to change the situation and allocate more resources to that sector. So these are aspects that are today that are important to our researchers. And I always said that when I was managing research, and I used to tell the researchers that you cannot behave yourself just like your European counterparts or European colleagues, simply because your European counterparts may develop some researches, they can publish, and they can continue their career.
Vous ne devez pas vous limiter à produire uniquement de la connaissance. Vous devez aussi accompagner.
You should also work in the use of this knowledge, and in so doing, you may develop other types of documents. These are scientific orientation documents, but these are a first-level document. It does not lead you to the decision maker. In other words, the document which is produced here, this may not activate the sensitivity of the decision maker, because at the same time, this is a rather closed down jargon with graph, diagrams, with scientific jargon. This doesn't mean a lot for a decision maker. This is the scientific jargon, as I said. It means that this document is yet to be explained in order to translate it in a jargon which can be accessible for the decision maker, because we should go in the linguistic environment of the decision maker, and then the document will mean something for him. Because the minister, he used to be a scientist, but now he has changed. His paradigm has changed. He has no time to read your document. It means that we need knowledge brokers, if we may say so. Some people that will take your documents, will work on this document, which may translate them in a jargon that will be accessible for decision makers. This is the importance of policy briefs. These are policy briefs, and I do think that this is yet to be done in Senegal, and this will be done with DCME. And today, this directorate is developing workshops where they will put together researchers, decision makers, technicians from the line ministry that will work on those research documents, and they will make a systematic review. They will use this document, they will work on it, and they will identify those dimensions which require to be better explained, to be translated in an operational approach. For instance, let's take this plate. You see that this document, which says that we have a decrease in the funding of RMCH in nutrition, and this has been demonstrated everywhere. But it doesn't say how we can take up that challenge. This is just a conclusion. And when the U.S. government has brutally stopped the funding, this is chaos. And I received a group of NGO. They came to tell me, Honorable Permanent Secretary, we came here to announce that the office in Dakar shall be closed down. And I say, why would you do that? They say, okay, because all projects that were managed by this Dakar office were funded by the USAID resources. And I responded to them. It means that you have what we call a long-term vulnerability. It means that today, when they are talking about resilience, a resilient mechanism, a resilient system, it means that they will say it like that because there is no mechanism whereby they can build any resilience, because once you have seen that you have only one partner in order to live, it means that at any time you may die. God forbid. And this should lead you to rethink your diversification. What does it mean? For this component which is related to the use of these type of documents, the use of this evidence-based data, it means that we need to strengthen the technical capacities of our researchers, but also of our decision makers, technical capacities for our researchers. This is not only to make data analysis and to produce some knowledge, no, but you need to know how to communicate, how to translate these data into practical policies. This approach is very important, and this is what you will have to develop for our researchers. But also, we need to create an environment of permanent dialogue and of permanent collaboration between researchers and decision makers. And today, this will lead us to develop what we call research implementation research, implementing research. It means that these researchers will act on the way we will try to solve problems. That is to say, they will give us the solution and they will develop with us the new approach. And then, while producing some knowledge, they will solve our problems. And this can capture the attention of our decision makers. And I do think that the director said it earlier. When you put 3 years to produce some knowledge, the decision maker will have only 2 years. And he will stay only 2 years in order to implement and convince and solve the problem in Senegal. It means that the researcher should be working permanently and with the decision maker. In research, you provide the dynamics, and this knowledge production, you give him the possibility to solve problems. That is to say, research implementation. It means that progressively we need research implementation so that our decision makers can be sensitive to the fact that research is the best way to go faster and to do it better. And I will conclude and say the following on the second question you've talked about, that is to say, partnership. Partnership in the development of knowledge, but partnership in the use of knowledge. Today, we have several dimensions which are interacting on the degradation of our population's health status. And here again, in the framework of this program in Senegal, we have the universal health coverage concept in order to show the multisectoriality in fast-tracking the UHC objectives with what we call health in all politics. What does it mean? It means that national education, agriculture, housing, urbanization, each of these line ministries should focus on being a contributor in creating a healthy environment. When I build my roads, I have to think of contributing in the health sector. When I do organize urban transportation, and we have an instance we saw in Kaffrine, where the regional director of health visited the Directorate of Transportation together with the municipal city because they had to organize urban transportation. He said that it would be good for them if we define the transportation system to think of health centers. If we look at transportation system, when they draft the system, they are talking about markets, they're talking about schools, and they can often forget about health centers. And this could enable us to improve accessibility. The same applies when national education puts in place a program. They should think of contributing in the health sector. And if all stakeholders, this should be the program. And this should be done from one program which we have drafted, which is called Strategy for Universal Health Coverage, with an accountability table. This accountability table will include all ministries, all sectors, and on each sector we will define a certain number of commitments and assessment criteria, and everything will move toward improving the health sector. This plurisectoriality should be analyzed in this framework, and this will enable us to include all approaches which are focusing on human rights compliance, and this is in line with complying with human rights. This is in a nutshell what I wanted to share with you. Thank you, Doctor, for sharing it. You rightfully pinpoint the key issue. Listening to you, researchers have been called upon. You are telling them, this is good, you are in research, but you cannot talk about research. We are not the best communicators. We need to build our capacities. We need other transitional documents in order to move from these scientific reports to something to have something else, that to say a new jargon. We understand your message. It means that the word of research is an additional dimension. No group can work in silo. It means that we will have to collaborate with other capacities so that this message can be understood and digested. Yes, we have set the tone. This is clear enough, listening to the panelists. And what we have to do now, we know that this will help us to improve policies and programs in RMNCAH. We'll have 2 or 2 questions. Yes, we know that we went far beyond time. If
to our moderator to get us maybe 1 or 2 questions that we will direct to the panelists, and then by answering those questions, they will also share their closing remarks, because we have a lot of we have gone beyond time. So over to you.
Thank you so much. First of all, can we have a round of applause for our brilliant panélistes? Des applaudissements pour nos panélistes qui se sont voués à l'exercice de manière si brillante. Merci beaucoup à chacun d'entre vous. Comme l'a dit
Thank you. As said Dr. Fay, we have time constraint. Presently, it is 15 minutes past 6. What we can do, we need to allow our panelists to give their closing remarks. If your questions, we will take only 1 or 2 questions, 1 or 2 comments, if you can think of the closing remarks of our panelists. And in so doing, we can conclude and move to the cocktail in order to conclude everything. I see a hand here behind. Yeah, the gentleman here and madam.
It's not a question, just a comment. I agree with everything that all the
Can you remind us your name, probably?
I've talked about.
Just remind us your name.
Oh, I'm sorry. My name is Latifa Ibisomi. I'm Nigerian, but I work in South Africa, so I'm from Johannesburg. So I agree with everybody that we need to have a common purpose, and we've heard about the several ways that people have suggested that we can do this. So I want to speak more to the equity-sensitive ways of doing that. The first one that I will talk about is when Professor Obama was talking. He talked about a specific place where people at the lower socioeconomic stratum progress were made, but at the upper level we did not see any progress. So the way to think about this is, if we talk about, for instance, a reduction in a particular indicator, say 2/3 by 2/3. So we just need to do our stratification in such a way that is possible, nothing that will cause any political tension, but maybe by rural, urban, and some other regions or whatever, such that we move that if we are targeting 2/3 in this particular stratum, we're also targeting 2/3 in each of the stratum. And this way we are able to make progress in each of the various strata, rather than just focusing on the particular one. And this will also go for even the intervention that we'll be talking about. Like when Professor Lund talked about looking at the continuum of care. When we look at the continuum of care, it does not necessarily mean that all the problems we have in the regions are the same. It may be somewhere for one region and another in another region. So we need to target what exactly is the issue in each of these regions and bring on board maybe the stakeholders, the community members, so that they see that we are addressing their issue and not as a result of political whatever. That is where we are addressing their context is different from what we are addressing in another context. So this will be another way to look at it in a kind of equitable manner. The third one I want to speak to is that we also need to assist the government to be able to spend the budget that is allocated to them. A very long time ago, 2009, I led the implementation of the Maputo Plan of Action. We did it in 9 countries. As at then, that was when we were trying to use the 15% allocation to it that was agreed in Abuja. None of the countries met that. By the end of the year, these guys are still returning money back to the coffers of the government because due to bureaucratic whatever, they've not been able to spend. And I remember one of the ministers asking me, what are you telling us? That we should allocate more, but you people will return at the end of the year. So how do we, especially now that we have this, our purses are already shrunk, how do we make them how do we assist so that these monies, they are better utilized? And even in some countries, all these issues that we are talking about, they are not line items in the budgets. How do we get this done? And my last comment is about, I look around the room, the people we are talking to, are they really here? How do we get the message to them? Thank you.
Thank you so much. La dernière question, c'était monsieur juste là. Ouais. Et pour les autres, vous aurez l'occasion de réseauter durant le cocktail.
Merci beaucoup.
Thank you. Good evening. It's Ed Somda, expert in health information at the West African Health Organization. We thank you for this initiative. Congratulations. I really wanted to take the floor after the words of Dr. Sambakor Sarr. Very important words, very strong words, mainly on the use of data. This is the topic of this topic for decision-making process. We have an academic team, which is not only academic, because this is an important team. They worked a lot, and they've been able to produce data and results that are very important. Now, how can we use such results as well? From what he has said, I think that ministers would not read Lancet, and they used to read it before. Ever since they became ministers, they don't have time to read the Lancet. Now, we have the opportunity to have people given the descriptions. They had several profiles in their past life. It's not the researcher and the minister, but knowledge brokerage does exist. We have many brokers in the process of decision-making. Once the Lancet is published, because these are elements that have not been seen in your interventions, what will be the role of NGOs? What will be the role of other partners? For instance, UN agencies, ECOWAS organizations, so that once the research has published in Lancet, once he is a professor, he is happy, these elements should be translated into a policy. Thank you very much. Thank you very much. Now, we're giving a round of applause for these two questions. Now we move to our panelists. They can answer the question because there is only one question and then one comment. Il y a une question urgente ici. La toute dernière question. Merci beaucoup.
I don't have questions. I have two comments. One is about universal health coverage. My name is Magda Robalo, and I'm the co-chair of the Universal Health Coverage Steering Committee. I saw universal health coverage being pinpointed as probably one of the reasons why focus on reproductive, sexual, maternal, and child health is became diffused. And I would like to argue differently. I think we have seen coverage has increased, actually, and even in some countries, and quality of services has increased. I think UHC has actually probably contributed to that improvement. So maybe we need to look into the data and then see whether UHC is helping or not. And if it is not helping, then we need to find out why, because across the board, we are promoting UHC by 2030. My second point is, or maybe let me roll back to say congratulations to Lancet and to everyone involved. I understand today this is the second launch of a report in Senegal, in Dakar. There is a gender equity report that is being launched, and I wish we could find ways of being together, because the issues are very much related. And then talking about that, I think again we are making a usual mistake. We are talking separately in silos of issues that concern the same people. We need to be talking about people-centered approach. And I would have loved us to be talking about women's health. If we look at the data on breast cancer, cervical cancer, if we were in a room just to discuss cancer, we will be saying this should be the top thing we should be doing for women because they are dying of breast cancer and cervical cancer, and we have tools at our disposal to prevent that. So as we bring maternal and child health and newborn and sexual and reproductive health to the center, let's do it based on people-centered approach. Let's look at women as one person with breast, with cervix, who also has cardiovascular problems, because some of these women who die while giving birth, they also have other problems that contribute to maternal mortality. Thank you.
Thank you so much for those comments. Back to you, panelists, pour vos conclusions et peut-être des éléments de réponse à la question qu'on a eue.
Yes, I do think that we would like to thank the speakers. They gave us a very interesting prospect and new dimensions. Now let us invite panelists in 1 minute for each to tell us what they think of all this program, what is the message they would like to convey, all the problems we've been developing here. I do think that Dr. Senon is ready to jumping with a message in 1 minute, but also to tell us in which direction we will be moving to. Countdown 1 minute.
We need a change of paradigm. We need to take a societal and multi-sectoral approach. Like the minister was saying, I think we've heard it and we all will agree. It's not just a health issue. I heard it's not just a right issue. We even heard from the GFF it's not just an economic issue. It's a development issue. So that's where I will stop, which requires that we take a holistic approach. Thank you.
Absolutely. Thank you so much. That's a very strong one, actually. And we take that one. Thank you so much. Joy, I think people have been challenging researchers here in the room. And we don't seem to be in the right room here. I don't know. But they all tell us that we are not doing the thing right. We are not doing right. So what is this thing that we are not doing right? And what's the message?
I agree.
You also agree.
Yeah, absolutely. What we need is not the researcher on their own, not the woman on their own, not the politician on their own. We need the politician to translate the Lancet document. But together, we can bring change. And to do that, I think, Senan, you said this, we have to use data to hold people accountable. We have to hold the US government accountable for broken promises. We have to hold our own governments accountable. We have to hold researchers accountable for doing better data. And if you think of accountability, the middle is count. And the last part is ability. So each of us, we have the ability to count. We need to communicate better. I agree with the minister. And we need to have people at the center. But we have no option but to do that. We can't just have numbers and ignore them. We can't just put them in Lancet. We have to count, use our ability, and make some change. So that's what I would say.
Thank you so much.
Thank you.
Very strong one as well. So thank you so much. But then also we've been challenging civil society a little bit because people are saying that, I was hearing the director, the cabinet secretary saying that there's a vulnerability within NGOs that rely only on one funder. So, and that vulnerability has become almost chronic So, but what's your take into engaging more civil society and NGOs into this issue?
I think diversity is good in everything. I feel like this panel was very carefully designed because it has different perspectives that are around the table discussing issues of our health programming. And I think this is the same approach that we need to take in our health programmings on a day-to-day decision-making setting if we want to take a holistic approach of fixing our systems. But colleague there has pointed out one missing key, which is the beneficiary. I think that the only person that's missing from this panel is the beneficiary, and we need to make efforts in bringing them into discussions like this so we can also hear their perspectives. Thank you.
Very good. Thank you so much. In fact, you are right, because all we do it for the beneficiaries. We want to improve their well-being. We want to improve our well-being because they are also part of us. So to what extent can we make sure that they are on the table? We co-design, we co-create, but also we co-implement. I think that's a very strong message. Thank you so much. Mais, Dr. Sambakor, là maintenant
Sambakor, I'm going to remove my hat of a politician. You are not a politician, in fact, but you know, in this discussion, it's not easy, and sometimes, you know, people are saying the same thing. We have produced a lot of things. We have talked to the government, to the decision makers, government authorities. You can convince them sometimes. Ibrahima was in the Countdown for many years, who knows everything that we have produced in terms of research. He will not understand. Don't tell me that he would not understand. He understands, but there are other parameters that we do not understand as researchers. But what should we do? How can we influence? How can we ensure that in 5 years, let's say, with all these problems, reduction of the funding or shrinking funding, the countries are on the right track, and all what you said about the countdown, what can we do so that the situation will not be worse in the coming years? And by saying so, can you make your closing remark, because at the end of the day you are hosting, and we are happy to say that it is Senegal has accepted to host this. We have thought about many countries, but at the end of the day Senegal has accepted to host this. So we would like to thank you, and we would like you to convey these greetings, these thanks to the ministry. So your opinion, your take on, and then your conclusion, observation. Thank you. Well, indeed, the observation that you made on the change of position of the minister that would influence the behavior, I think that the sociologists and the psychologists know very well that the minister in his university environment, Ibrahim Massi, I mean, the Minister of Health, who is now in a ministerial position, not as an academic, you can see immediately his behavior has changed. He can no longer have the same mechanism, reflect the same ideas. There are other elements that come into play with a setting, with a way of seeing things, which means that if you give him this document today, as the minister in charge of health and social welfare, you may not have the expected outcome in relation to the use that should be done with it, because he is on various issues with another way of operating. He is no longer the same, which means in clear terms that to help him to make a good ownership of this document, you should support him. Support him by putting in place what we call a roadmap. A roadmap that should help to produce two types of documents which are still called the policy briefs. With this document, you can develop many policy briefs. These may be neutral policy briefs. A neutral policy brief is a policy brief that helps to the others who are not scientists to better understand what you've said in this document. So it is only for dissemination, or dissemination of the document, not in the form of scientific article, but in the form of a document in an accessible language for the layman of the system. This is what we call a neutral policy brief, but you can also have some interventional-based policy brief. Those policy brief would serve as would help Dr. Doucouré, for example, to act on the basis of the outcomes which are generated in this report. This is the interventionist or the intervention-based policy brief. That is a policy brief that would push the decision maker to act. As long as he does not act, or he would not act, would not achieve your goal. This is a work that should be done by the researcher who knows the outcome, he knows the method he has used, and who can help to a better understanding with the decision maker or the practitioner in the area, who should help him to formulate guidelines that may reach sensitivity of the decision maker. These are extremely important aspects to be developed. That's why I always say that our researchers should no longer stick to producing research reports. They should go further than that. They should do more than that. They should integrate the team of the decision makers, work with the decision makers team, explain further the outcome that they have achieved, and with that they can transform the document into a policy brief that would be used in interventions or other neutral policy brief. Now I would like to tell you that this approach, which consists in sharing a report, a written report, in a scientific approach, is a part and parcel of the means that can help the professionals of the sector to better interact with the language, with the systematic language or the science language. And I think that these are approaches that we should encourage. We should disseminate this kind of approach. Today,